So what I'm going to talk about today, well, the title sort of says it all. I'm going to talk about what linked administrative data can tell us about inequalities in child health, but also where the barriers and challenges are and where it might fall short. So I'm going to draw examples from ECHILD, which is, as Peter mentioned, a data resource linking health, education and social care records at population level in England, so captures around 20 million children currently. But I think the methodological issues that I'll raise will be relevant to other types of administrative data as well. So hopefully, yeah, I can tempt some of you to think about how these types of data might be helpful for your research. Okay, so first, what do we know already about inequalities in child health in England? 2 years ago, the Academy of Medical Sciences published this report highlighting an appalling decline in child health in the UK over recent years. And the statistics were quite shocking. They tell us that 1 in 5 children are overweight or obese by the end of primary school. 1 in 4 have tooth decay. There's been an unsustainable surge in demand for mental health services for children and young people. Infant mortality was ranked 30 out of 49 OECD countries, and the number of children living in extreme poverty had tripled since 2019. And as well as being, quite shocking statistics on their own, they also track differences in deprivation, ethnicity, and geography. So if you're born poor or in the wrong postcode or in a family with limited access to services, then health and educational prospects are substantially worse. And these disadvantages persist throughout childhood and into adulthood, which is why it's so important, I think, when we're thinking about inequalities, to start with childhood. Part of what makes it difficult to study inequalities in childhood is that a child who is struggling might be seen in hospital, might be flagged for additional support in school, or might be referred to children's social care services. And historically, none of these data systems were really talking to each other. It's a problem for research because it can make it difficult for us to see the whole picture, but it's also a problem for care because children can be at risk of falling through the cracks or the gaps between system boundaries, and particularly those with complex needs who are seen by different services. So today I want to talk about 2 questions or topics. The first one is quite descriptive. What can administrative data tell us about the scale and pattern of inequalities in child outcomes? What does it add to the picture that we already know? And then the second is more causal. Can we use these data to evaluate whether early interventions work? So going beyond documenting inequalities to understanding whether we can intervene to change them. And I think the answer to this second one is more complicated. But before I go into that, I wanted, for those of you who haven't worked with administrative data previously, to explain a little bit about what we mean. So admin data are records that are created through the way that we interact with services. So if you go to A&E, a record would be generated when a child sits their school exams, a record is generated when a social worker makes a referral, a record is made. And the records are generated to help systems and services administer their services and being reimbursed for those services. They aren't generated primarily for research purposes. So this can be both a strength and a limitation. The advantages of these sets of data are there's no sampling, there's no attrition, there's no dropout, there's no recall bias. So some of the traditional challenges of research data or traditional cohort studies are avoided. And then we capture everyone who uses the service, which gives us near population coverage. For rare conditions or for small groups, this means that we have a huge amount of statistical power to answer questions that just aren't possible with traditional research studies. And then theoretically, at least, these data should be cheaper to access because they've already been collected. We're not doing primary data collection, and they should be more timely because we don't have to start a cohort and then follow children up for years to find out what the outcomes are like. We can look back retrospectively. But there are disadvantages. You can only see what the system records, so there's no bespoke measurements, there's no patient-reported outcomes, there's no information about what happens during an interaction with a service. Missing data are often a problem, and even where we have complete data, there might be missing contextual information, so things that we would want to know but that aren't recorded in the data. For example, direct measures of poverty or family functioning. And then importantly, if certain groups of children are less likely to access services and they're less likely to appear in records, then they're also less visible in the data. So there can be problems with selection, even though we've got such high population coverage. Moving on to ECHILD then, this is our linked data resource for children in ECHILD, which sits at the intersection of health and education. It brings together health data from NHS England, which falls under hospital episode statistics or HES. This includes inpatient admissions, A&E attendances, outpatient attendances, all going back to the late 1990s. And then the National Pupil Database from DFE, which includes standardised attainment tests at ages 5, 7, 11, 16, absences, exclusions, things like free school meal eligibility, special educational needs provision, and also children's social care is included in the National Pupil Database. We then have a mother-baby link, which allows us to look at maternal and sibling characteristics, and we have information on maternity services, mental health services, community services data, as well as births and deaths. So all of this linkage within ECHILD allows us to bring together different pieces of the puzzle that have traditionally existed in isolation, but that gives a sort of more holistic view of childhood. So this allows us to build a more detailed picture of how children interact with different services over time, and how these domains may interact with each other and affect outcomes over the life course. And this is really important because children and families don't view these different parts of their lives as being separate, and they've often voiced to us frustration about having to repeat their stories in lots of different places to different services. So by linking these different parts of children's lives together, we get a better idea of where services might be able to provide support in joined up and cohesive ways. And again, because we've got the population level data, we've got the statistical power to look at inequalities, disparities across different intersecting demographics, and also to compare, to consider rare outcomes or small subgroups of the population that hasn't previously been possible. But having said that, the scale of the data doesn't fix some of the problems with observational data. There's no randomization. We don't have information about the quality or content of many of the services that we capture. And we don't really understand how children and families feel navigating these different systems. So powerful data with lots of potential, but have their limits. And I think understanding the types of questions that these data can answer well is really important. And that's what I'm going to try and cover in the next few slides. So one of the first studies that we did with ECHILD, led by Nico Luboy, followed children born preterm and tracked their chronic conditions in health data and school attainment in the education data from reception through to year 6. So this plot shows the percentage of children meeting the expected levels at their key stage 1 and 2 tests, which are at ages 7 and 11. Because we had data of the whole population, again going back to the size of the data, we were able to quantify the effect that each additional week of gestation has, and show that being born even a couple of weeks too early can have a lasting impact on children's abilities to learn, which persists till the end of primary school and probably beyond. So rather than grouping together preterm pregnancy as less than 37 weeks, as has often been done in research studies, we were able to look in much more granular detail. And this is helpful because being born at 24 weeks will have very different impacts than being born at 34 weeks, for example. This is a descriptive study. We don't have information on all possible confounders. We don't have information on maternal smoking, for example, that might be related to both pregnancy and child attainment. But it's useful still for quantifying the scale of the gap and provides information about the likely challenges that children might face, irrespective of the mechanisms by which they were brought about. So this allows us to raise questions about what early support might be needed to enable children who are born preterm or with chronic conditions to start school without being at a disadvantage to their full-term peers. Through the HOPE study, we looked at gaps in educational outcomes across school age in children with a range of different health conditions. And this example here comes from, focuses on neurodisability. So this plot shows the proportion of children with and without neurodisability recorded within hospital records prior to starting school age, who achieved a good level of development at the end of reception. And these patterns continue through Key Stage 1 and through Key Stage 2. So among children who were assessed, the attainment gap compared to children without neurodisability widens over time from 57 versus 30% at age 5 to 74 versus 46% at age 11. But there's also, importantly, a big increase in the percentage of children who aren't assessed, who aren't included in assessments. And that increases from 1.5% at reception to 31% in year 6. So there are two things here to note. I think one is the absolute attainment gap, which is large and widens over time. And then secondly, there's the not assessed category, which includes, it might include children who are absent from school, it might include children who've moved out of the state school system, and it might include children who aren't put forward by schools for assessment. So again, I think this allows us to raise questions about the suitability of the assessment process and the support that's in place within school for children with neurodisability. Because when a third of the group can't be measured using a standard tools, then I think this tells us something about the usefulness of that tool. Another study, this one led by Anya Silverstein and Isabel Ward in our group, looked at mortality in a cohort of almost 3 million secondary school pupils over 12 years. The group of children receiving social care interventions only, and social care and special educational needs interventions within school account for a small minority, 1 in 15 pupils approximately, but these children had between 5 and 7 times higher risk of death compared to their peers. We looked at the causes of death, and risk of injury related death was significantly higher for both girls and boys in this group, the group of children receiving social care with or without SEND support. And these injury related deaths are potentially preventable through better support. So again, these children are being seen by services, but seem to be falling through the gaps in terms of their risk of mortality. So this allows us to ask questions about whether better coordination of health and education, social care services could mitigate these harms, whether better access to mental health services is needed, or better transition from children to adult services. So this is a small group again. The children looked after population within children's social care account for less than 2% of secondary school pupils. But within that group, there's quite a concentration. So 75%, 3/4 of that group would have SEND support or an education and healthcare plan. And I think the benefit of using administrative data here is that traditional research might find it difficult recruit these groups of children, but that they do appear they are visible within administrative data. And then a final sort of example here is around stress-related hospital admissions during term time and school holidays, a study which was led by Ruth Blackburn. So this plot shows the rate of stress-related presentations in hospital admissions, and you can see across all secondary school ages, there's a pattern where we see admissions peak during term time. And these stress-related presentations are predominantly for mental health problems, self-harm or pain, and they are quite common. They affect 2 girls and 1 boy in every classroom. We don't necessarily know what's causing these presentations. It could be school-related stress, or it could be that schools are a point at which these issues get recognised. So it's a point for identification and then referral. So we do need to do more to understand why we see these patterns and what we could do to prevent them. But I think this is a nice example of how we can use the temporal nature of administrative data to reveal structure and patterns in large populations. So far I've been talking about children more or less in isolation, but like health and education don't exist in isolation, neither do children. They're part of families. We've got linkage between mothers and babies in ECHILD, which brings together hospital records for currently around 8 million mothers and 14 million babies, which covers approximately 90% of births in England. So this allows us to look at questions about intergenerational transmission of inequality. We can think about how maternal health circumstances or social care history or mental health shape children's trajectories. We can start to think about how conditions and outcomes cluster within families and the effects of having a health condition, not just on the child with that condition, but also on their siblings. And again, this is something that our PPIE work has highlighted as being important to families. A mother who has a child with a brain injury is obviously concerned about that child, but they're also worrying about their other child who has to miss out on lots of opportunities because the mother has had to leave work to care for the younger child. So thinking about that family context, I think, is really important. And then an area that we've not really taken advantage fully of yet is whether we can use these siblings as controls to account for shared genes and environment through having the same mother. So this was a study that we did looking at pre-pregnancy psychosocial risk factors using data from 2 million mothers in England. This plot shows the relationship between maternal age and birth weight, according to whether the mother had a history in hospital records of mental health conditions or hospital admissions for adversity in the red, which includes violence, self-harm or drug and alcohol misuse in the 2 years prior to birth. And these groups together account for a small proportion of mothers, about 4% overall, but you can see that they're at a higher risk of having a low birth weight baby. And you can also see the pattern by age where birth rates are lowest for the youngest and oldest mothers. And then the second plot here shows the relationship with infant admissions for injury, which shows the opposite pattern. Injury admissions are higher for the younger mothers, but still for the older mothers, the ones who we can identify through administrative data, those with a history of adversity or mental health conditions also had poorer birth and infant outcomes, as did those living in the most deprived areas. So these numbers represent inequalities in infant outcomes, in early outcomes, but ones which are partially determined, at least for birth, in relation to the circumstances of the mother. More recent work from Steffi in our group takes this further by looking at mothers who themselves had social care involvement as children. She looked at around 150,000 mothers aged 17 to 24, about a quarter of whom had involvement with child social care services as an adolescent. And we can see that in outcomes for children, even after adjusting for a substantial set of covariates, show elevated risk, particularly for mortality. And because we've got linkage with the child educational records as well as the mothers, we can look at child educational outcomes. And here we looked at school readiness again at age 5 and didn't see a huge difference between groups, although this was a smaller sample. So these data can help us think about whether services are adequately supporting young parents with care experience and about how intervening might interrupt these cycles of adversity. But one thing to note here, which I think is important, is that this is still descriptive work. Even with a rich set of covariates here, there is likely to be residual confounding. Mothers with care experience will differ from other mothers in many ways that we can't measure within administrative data. So I've hinted at what we can't learn about causation already, but I think what I've tried to show so far is that linked data are very powerful for descriptive work. They let us quantify gaps that have previously been unmeasurable because of smaller sample sizes, and reveals which groups of children have the most complex needs and who might be less visible in other data sources. And these data also allow us to trace how disadvantage compounds across the life course and across generations. So though the statistics are simple, we're talking about straightforward descriptive work, I think this is really key to understand how services are working on the ground before we can think about how we might improve them. One of the recommendations from the AMS report that I mentioned at the start was that we should be implementing effective early years interventions. And part of the rationale for this was that it's been estimated that the cost to society of addressing issues that might have been avoided in early childhood is huge. So there's this clear imperative to intervene early. And that leads us to the question then of whether we can use linked data to evaluate what works. So I'm going to give you three examples of where we've tried this. The first is the Family Nurse Partnership. This is an intensive home visiting programme for first-time teenage mothers, which runs from early childhood to the child's 2nd birthday. There's some RCT evidence of benefit from the United States, but the UK trial, which enrolled around 1,600 mothers, had more mixed results. The plot on the right here shows the percentage of eligible mothers in each local authority who were enrolled, and due to there not being enough spaces commissioned to reach everybody, around 1 in 4 eligible mothers would have been enrolled. So that gives us a way to evaluate the differences between eligible mothers who were or who were not enrolled. But one of the challenges we have is that the ones who were enrolled aren't randomly selected, and the factors which might determine enrolment are also likely to be related to outcomes. This table shows the characteristics of the mothers who were enrolled and not enrolled. There's about 26,000 mothers enrolled and 130,000 not enrolled in the study. And you can see those who were in the FMP tend to be younger, slightly more deprived, more likely to have a history of mental health, chronic conditions, or A&E attendances in the health data. They're more likely to have had special educational needs at school and have been in contact with social care services as a child. So this is good because it means that the service, the FMP, is being targeted at the mothers who need it most. But it creates a problem for analysis because we know those more disadvantaged mothers who are more likely to be enrolled would more likely to have worse outcomes. So in this analysis, we used propensity score matching to control with the confounders that are associated with both enrolment and outcomes. And this allowed us to firstly estimate the probability that each eligible mother would have been enrolled based on everything that we can see here: age, deprivation, ethnicity, prior health contacts, etc. And then match each enrolled mother to a non-enrolled mother. And the idea is that within the matched cohort, enrolment is then approximately as good as random, conditional on the factors that we have in the model. What we found in the data was quite mixed. The primary outcomes were related to our treatment, and in our propensity score matched cohort, we saw generally little difference between groups, except for a small increase in hospital admissions for maltreatment or injury related diagnoses in the FMP arm. So this might be counterintuitive because we might have expected that the FMP would reduce these admissions. For maternal outcomes, we saw, again, increased admissions in the 2 years following birth. We also saw a small decrease in rapid repeat pregnancies. And then for child outcomes, we again saw that increase in hospital admissions, but we did see in the FMP arm a small increase in the percentage of children meeting a good level of development at age 5. So there are a couple of things to discuss here. I think firstly, it's very likely that unmeasured compounding remains because we weren't able to capture all of the reasons why some mothers were involved in the programme over others. We don't have information on family support, like who's within the household, are there grandparents and parents there? We can't capture granular detail on household income, and we don't know whether the mother, for example, was experiencing domestic abuse. And this signal of unmeasured compounding is supported by the increase in the percentage of babies with low birth weight, which you can see in this towards the top of this plot. We wouldn't necessarily expect that the intervention could, given it's given in late pregnancy, we wouldn't expect that it would be able to reduce birth rate. So the fact that we see more low birth weight babies in this arm, despite having tried to account for all of the confounders that we observed in the data, suggests that unmeasured confounding might be masking the effect or the full effect of the intervention. And the second point is that it's difficult to interpret the direction of some of these outcomes. So when we were discussing these results with the FMP nurses, particularly taking, for example, the maternal mental health admissions, they said they do a huge amount of work with mothers to address the trauma that they have experienced in their lives, and that can bring up things that means that the mothers might be more likely to recognise that they need support with mental health. So the FMP nurses were saying maybe this reflects increased recognition rather than increased underlying issues. And I think that goes for the unplanned admissions here as well, and A&E attendances, which might reflect appropriate healthcare seeking behaviour rather than underlying need. So there's probably a few different things going on here. Okay, moving on to another example of an intervention. We also were interested in health visiting more broadly. Health visiting is a universal service which is specifically designed to reduce inequalities through a proportionate universalism approach, which means that it's universal in reach, it's offered to everybody, but it's targeted in its approach, which means that the families who need more support receive more support. Health visitors are trained nurses, and they're sort of uniquely placed really in terms of all available services to influence and work with the whole family in the interests of children and children's outcomes. During the first 5 years of life, families should receive 5 mandated contacts plus an antenatal contact. And the idea is that these contacts promote health and development and enable early intervention to improve long-term outcomes. But health visitors, because of this targeted approach, are also designed to be responsive. So if children need or families need additional support, then they would receive additional contacts over and above the universal offer. So there's a lot of interest. There's a lot of interest in whether more health visiting is associated with benefits or cost savings for children and families, cost savings for the government around children and families, particularly around the government mission to improve school readiness, for example. But because health visiting is a well-established universal service, it doesn't lend itself easily to evaluation. There's no obvious comparison group, for example, of families who didn't receive health visiting. We do know that delivery varies across populations, geography, and has changed over time. So this does give us some opportunities for comparisons. But the challenge here is how we define the intervention and comparator groups for such a universal and complex intervention. And to do this, we used a target trial emulation approach, which required us to set out very clearly how we define these comparator groups, who is included, who is excluded from analysis. So it gets quite complicated, but this diagram is trying to show the complexity that we have in assigning families to treated or controlled groups. So we first define the follow-up start and the follow-up end date. And here we use the new birth visit, which usually takes place within the first week of birth, and then 330 days since the new birth visit, which takes us up to outcomes up to age 1. The outcome in this trial, or this emulated trial, is unplanned hospital admissions. And then we defined those families who had an additional contact in the first month of life as having enhanced health visiting, so they're the treated group, and then families who didn't have that additional contact in the first 30 days would have been the control group. And then those with the outcome of hospital admission within the first 30 days, which is the period in which we assign the intervention, are excluded from analysis. So it's quite difficult in observational data to think through these things. And I think having the target trial emulation framework makes you be very explicit about who is treated, who's in the control group, where the outcomes fall, who needs to be excluded, and what the follow-up period looks like. But okay, so in unadjusted analysis, comparing those who had enhanced health visiting versus the universal offer, those receiving more health visiting were more likely to experience avoidable hospital admissions, which is what we'd expect. The more disadvantaged families, again, would receive more health visiting, and they would be also more likely to have avoidable hospital admission. But even when we controlled for a large amount of maternal characteristics, including these ones here, amongst others, and here again we used a propensity score approach, the results were still in the opposite direction to what we might have hoped to have seen. So it still appears that children who receive more health visiting are more likely to have avoidable hospital admission. Although this adjustment did attenuate the effect size a little bit. So again, at this point, we can ask whether, well, does this mean, does health visiting really increase the risk of avoidable hospital admissions? Or we could also ask, are we using the data in the most appropriate way? Our studies on health visiting have included significant qualitative research components, which have really helped us interpret what we see in the data. We know that we're missing part of the picture. We don't know why these additional contacts happen. And the qualitative work has helped us highlight the complex reasons for this, which might include other specialist services support for complex problems, and then the local context, including poverty. These are things that we just don't capture in the administrative data. Our qualitative work has also highlighted the huge impact that health visitors can have on children and families. I'll leave this here for a minute. I think it's a nice reminder that beneath the data, there are real individuals with stories that can't be captured quantitatively. So things that we can measure easily in admin data, like hospital admissions, might not be the outcomes that interventions like health visiting are designed to change. And what this mother is describing here is something about maternal confidence, parenting capacity, early attachment, and the prevention of a crisis before it happened. Okay, then the third example here is on special educational needs and disability, or SEND provision. And again, going back to the HOPE study, in this project, we were attempting to evaluate the impact of SEND on health and educational outcomes. And we used a range of methods, including target trial manipulation, but we were faced with some of the problems that we've already discussed. So we're going to talk about these challenges in the context of HOPE specifically, but I think they apply more broadly, including to the examples that I've already given. So the first challenge is confounding. If we want to evaluate whether SEND works or not, we need to understand the reasons why one child would be supported through SEND while another wouldn't. Administrative data record the services that a child received, but don't capture the reasons why they received that service. So a child with SEND support or a mother who's enrolled in the FNP or family receiving health visiting more frequently, they're not randomly drawn from the population. And we often can't adequately measure the needs that drive those interventions. And in this case, we tried to narrow down our analysis to a relatively homogeneous group of children, including an example where we just looked at children with cerebral palsy. But even with that group, and even using propensity score target trial emulation approaches, we can only adjust for what we have in the data, and we can't account for things that aren't captured. The second challenge is defining the intervention. So we know from the MPD whether the child had SEND, but we don't know what activities were actually delivered, at what sort of intensity, by whom, or how the child and family responded. So we can't, this makes it difficult to distinguish the question of this intervention doesn't work versus this intervention wasn't delivered as intended. And services like SEND and health visiting are variable, they're under-resourced, and we've been asked by stakeholders when talking through this work, well, what will you get if you try to evaluate a broken system? And in the HOPE study, the qualitative work showed us that young people and parents and carers reported frequent delays in receiving support, watered down activities, activities that the child couldn't tolerate, and then a lack of capacity, skills or ability of staff to adapt activities to specific children. And then third is appropriate outcomes. I've already discussed whether hospital admissions are always appropriate outcomes to measure. They might be important, as are attainment scores and absences that we can look at in education data, but they're not necessarily the outcomes that interventions are designed to improve. They're sort of further downstream of the more proximal changes that services are aiming to produce. So if health visiting improves parental confidence, that improvement is valuable, but it might never translate into a measurable reduction in admissions or absences, for example. And the young people involved in HOPE study talked about feeling happier, having an improved sense of self, feeling less anxious or distressed, and being able to participate and socialise at school, which are all obviously incredibly valuable outcomes, but not something we can capture in administrative data. So lots of negatives there, or potential negatives, but hopefully some solutions. For the confounding issue, I think if we can continue to expand our data linkage, then there are places we can obtain more granular data. Primary care records, for example, prescription data, income data. These would help us capture more of the factors that drive selection into services. And sibling designs and natural experiments could help provide additional controls. But I think ultimately there will be some causal questions that observational data can't answer. And then for defining the exposure and intervention, I think we need to supplement administrative data with process data and better recording what is delivered and when and how. And then for outcomes, maybe this is where we can complement administrative data with primary data collection. And I think co-production and qualitative work also comes in as being important here. And the health visiting study was a really good example of how we can integrate these types of data from the start. So administrative data is an important piece of the puzzle. And I think its value could be increased when combining with primary data collection, careful methods and qualitative evidence. So to summarise about what we can learn, admin Admin data linked to administrative data can provide a fuller picture of inequalities across sectors. It can help us map the scale and pattern of inequalities at a national level, including for rare subgroups and over longer timescales. They can help reveal groups in which disadvantage is concentrated and help provide the family and neighbourhood context. They're useful for helping generate hypotheses and asking questions about which children are falling behind, where gaps are widening, and where services aren't meeting the needs of the population. And they can complement survey and qualitative work. And then a final note on what we can't learn. I've not gone into a lot of detail about, but the people who are missing from administrative data are also important. We often think of missing data as a technical problem that we can account for in some way, but in administrative data, missingness is also a signal. The absence of a record isn't random, but it's a sign of who isn't accessing services, who might have opted out, or who's been lost in the linkage process. And we know that coverage in ECHILD varies according to ethnicity, region, deprivation, and even clinical characteristics. And also that the children who are less likely to appear in the data might be driving some of the worst outcomes. So data quality is always important to think about as an equity issue and not just a methodological one. I also want to say something about the importance of team science on this work. ECHILD is a huge data set. None of us know all of it, so we really rely on each other to have expertise in particular components of the data. I've presented studies from lots of researchers within our team today. We're constantly learning from each other and sharing knowledge, and I think working in this way has been really important. So I'm very grateful to everyone whose work has contributed today. So thank you for listening, and watch this space for ECHILD, because Charlotte is going to be doing some work on the uptake of early childcare provision and looking at whether it's possible to use a target trial information framework to determine whether delaying school entry for particular groups of children might result in better outcomes or not. Thank you.